Good afternoon, everyone. Welcome to the Power of AI in Care Management webinar. I am Nida Shahid, your moderator for today's session. Before we start this session, let's take a moment to introduce our expert speakers here. Joining us today are Dr. Shardul Mehta, our client solution architect, who leverages his clinical background and in-depth knowledge of the value-based care world to delve into customer needs and deliver relevant solutions and demonstrations. He has years of experience in understanding customers' processes and workflows to map out effective strategies and approaches that help drive their success. Next, we have Hassan Naseer, our product owner. Hassan is a product owner at Persivia Inc., which focuses on Soliton AI healthcare automation. He has 4 years plus of experience in product management across startup stages. He holds a master's degree from Lahore University of Management Sciences in Healthcare Administration with certifications in healthcare delivery economics. Next, we have Dr. Naveed, and our AI engineering manager. Dr. Naveed is currently an engineering manager at Persivia, focusing on AI, previously served as director at Nucus Fast, and is the co-founder of Amal and founder of TIB AI. He holds a PhD in bioinformatics from the University of Illinois Chicago and has extensive experience in academia. His interests include AI in healthcare, bioinformatives, and digital pathology solutions. So let's start with this. But before that, we are thrilled to have such a knowledgeable thought leaders to guide us through today's session. Before we begin, a few housekeeping items. If you have any technical issues during the webinar, please use the chat function to reach out to our support team. We encourage you to ask questions throughout the session using the QA feature on top, and we'll do our best to address them during the QA segment at the end. This webinar is being recorded and the recording will be made available to all registered participants. Now let's start with our first speaker, Dr. Shardul Mehta, who will walk us through the insights from the Gartner report. We will also discuss considerations for selecting AI vendors and strategies to mitigate risk associated with AI adoption. Dr. Mehta, the virtual stage is all yours.
Hi, thank you, Nida. So today, like Nida said, today we'll be talking about the need for care management and why it's essential to improve patient outcomes and overall well-being. Specifically, how the entire process of care management is made more effective and efficient when utilizing AI. Care management is essential to manage care for patients with chronic diseases, to manage utilization, and improve health outcomes. In the United States, preventable hospital admissions account for billions of dollars in preventable costs. While chronic diseases are among the leading causes of death, heart disease and cancer combine for a total of about 38% of all deaths. Now, some background information on the environment and how chronic conditions affect the healthcare landscape. There's a disproportionately high cost associated with managing patients with one or more chronic conditions compared to patients without chronic conditions. 32% of adults with 5 or more chronic conditions have at least one ER visit per year. 24% of adults with chronic conditions have an average of one inpatient stay and up to 20 outpatient visits each year. This is 10 times the rate of adults without chronic conditions. Per the CDC, America spends $4 trillion annually on healthcare. 90% of that spend is on patients with chronic and mental health conditions. %60 of American adults live with at least one chronic condition, and 12% of all American adults have 5 or more chronic conditions. Based on CDC estimates, 6 in 10 adults in the U.S. live with at least one chronic disease such as cancer, heart disease, or diabetes. At a high level, care management is a set of services and activities provided by care managers or other healthcare professionals to help manage the overall health and well-being of patients, typically with one or more chronic conditions. Care managers proactively reach out to patients and offer services and preventive interventions to potentially reduce ER visits, readmissions, and improve the overall health of patients under their care. Oftentimes, despite care managers' best efforts, many of these initiatives result in suboptimal outcomes. Care management involves coordinating and delivering healthcare services to patients efficiently and effectively. These care management initiatives often become ineffective due to a multitude of factors and circumstances. For example, number one, of course, we have the elephant in the room, the rising healthcare costs. It is a constant battle for providers to balance quality of care with the financial strains of the system. Then we have our aging population, the fact that many of the patients are elderly with multiple chronic conditions. They require ongoing attention and resources. Then we also have provider burnout. Healthcare providers are overworked and stressed while being inundated with clinically complex patients. Of course, this impacts the quality of care that they can provide. Then we have the complex value-based care models requiring providers to juggle the care of patients, the cost of patients, the quality of care being provided to patients, and their patients' risk. As a result, the care management team is forced to focus on transitions of care and avoiding readmissions rather than focusing on providing comprehensive care services to their patients. We are often dealing with incomplete data sets, resulting in an incomplete picture of the patient's status. For example, risk stratification does not typically include social determinants of health, even though we know that SDOH plays a huge role in patient outcomes, yet they are rarely factored into care management strategies. In addition to having an incomplete picture of the patient's status, insights gleaned from patient data for care management is based on past data, typically resulting in a retrospective insights and not predictive insights. Typically, patients are identified based on the conditions that they already have and documented, not based on the conditions and costs that they are likely to acquire in the future. As a result, we are missing out on opportunities for early intervention and prevention. So when we talk about ineffective care management initiatives, it's not just one thing contributing to the ineffectiveness. It's a whole host of factors that are at play. Now, AI, when used effectively, addresses the areas where care management proves to be ineffective and empowers providers to more effectively and efficiently manage patient care in a complex healthcare environment. AI aids in care management by automatically helping to identify high-risk patients based on a multitude of configurable parameters. It helps to prioritize workloads, automates tasks and reporting on task performance to help improve operational efficiency, provides proactive care and patient education. It also helps to provide an overall efficiency of the care team, allowing the team to be more efficient and effective at managing more patients than ever before. In order to achieve these ideal outcomes, AI needs to be strategically implemented with those goals in mind. Initially, focus on value and fit. Don't chase trends based on historical data. Make strategic investments. Weigh risks and costs of the team and their time versus the value of the outcomes that you expect to achieve. Essentially, focus on the biggest bang for the buck. Start small and scale up. Focus on low-hanging fruit and be ready to make small adjustments to your approach based on experience and outcomes. And ensure data maturity. Without the right data, it's impossible to have a complete picture of your patient's health and overall well-being. Having the appropriate data infrastructure and expertise to not only integrate data but also ensure that data continues to flow is of the utmost importance to ensure that you're providing the necessary analytics and insights needed for success. Now, according to Gartner, AI is the cornerstone of an effective care management approach. Here we have a generalized flow of AI use cases along the care management spectrum, starting with identification, then stratification, engagement, management, and finally outcomes and reporting. During the identification stage, AI is used to model emerging and rising risk. This entails an analysis to uncover hidden trends in data to identify patients for care management programs based on their likelihood of becoming high cost in the future, or chronic disease patients, or any potential escalation of their current status. This leads to potential future cost savings by being in a position to mitigate high cost events before they even happen. AI can also help with stratification of patients with the patient prioritization modeling. By ranking patients for outreach, allowing care managers to prioritize their caseload, increasing efficiency, and ensuring the highest value potential members will be targeted. Next, we have engagement, where we can utilize generative AI to auto-compose clinical messages, healthcare outbound messaging, and care and patient care navigation. For example, AI can generate a first draft of clinical notes to reduce the burden on care managers to increase their efficiency. AI can also help generate patient-specific messages, taking into consideration the patient's preferred language, cultural, and emotional sensitivities, with the aim of reducing the burden on care managers and improving patient satisfaction. And also to provide conversational assistance to support patients with things like checking insurance eligibility, appointment scheduling, service availability within their area, and more to reduce friction and increase efficiency and patient satisfaction throughout the care navigation process. AI also helps with the management phase of the care management spectrum. With AI generating the next best action, AI analyzes the patient's data and suggests a patient-centric next best action to the patient or care team to maximize outcomes or engagement. AI can also help auto-generate patient-centric care management program assessments, education materials, and encounter summaries to reduce the burden on the care managers and increase the overall patient satisfaction. And finally, we have outcomes and reporting. AI augmented data analysis and interpretation allows for ease of data preparation, report generation, insight gathering, and analysis from the entire spectrum of end users, regardless of their varying skill sets, data comfortability, and literacy, with the aim of improving efficiency and the ease of decision making. Here we have some key considerations for organizations gearing up for AI-enabled care management. Number one, you have to evaluate your organization's readiness for AI adoption. As with most big changes, it is important to ease into AI. Start small with lower risk use cases and scale up from there as your organization becomes more comfortable with AI. Next, assess your data infrastructure and technology capabilities to ensure you have a rich and comprehensive data pipeline to integrate AI in order to facilitate the most accurate insights for your workflows. And also assess your workflow readiness and identify the need for training or additional skill sets required for your team who will be working with and interacting with the AI technology on a day-to-day basis. Finally, what factors should be taken into consideration when choosing the most appropriate AI vendor for your organizational needs? Assess your needs so that your organization's specific pain points and use cases are addressed. Take into account your existing technology. Whatever vendor you choose to work with should be flexible to work with and enhance your existing organizational infrastructure. Evaluate its impact on your users' workflows and how much training will be required. And also evaluate the potential vendor's overall clinical experience and knowledge of the industry. A vendor with deep clinical experience with data and the healthcare industry can prove to be an invaluable partner. Research vendors to ensure you are considering that you're considering to partner with. Find the right vendor for your organization, which finding the right partner for your organization is critical for your future organizational growth and maturity. And of course, engage your stakeholders early in the vendor vetting process. Buy-in from stakeholders is essential to success. Thank you. That's all from my side, Nida.
Thank you, Dr. Shardul Mehta. That was very helpful. Now, turning to Dr. Hammad, who will talk about Persivia and Persivia's AI initiatives.
Thank you, Nida, and thank you, Dr. Shardul, for taking us through the Gartner's report. That was very insightful. So I'll try to plug in a high-level view of where Persivia is with the current AI implementation before Hassan takes you guys through the actual workflows of our current state. So with Persivia, we have more than 15 years of industrial experience working with healthcare organizations from coast to coast. We have a single integrated platform that goes all the way from ingesting data to providing insights at the point of care. So our robust data fabric consists of thousands of data elements, measures, and clinical knowledge assets. We have unmatchable clinical depth, specifically hundreds of clinical programs and care pathways. We have an AI tightly integrated to all of these workflows. Particularly, if we have bidirectional connectivity into the EHRs, which means that we can take out the data from the EHRs and put it back in after an operation has been performed. We have a single longitudinal patient record that flows through the system. So, for example, if a patient visits one particular hospital and goes to another one for another disease management, we put it all together into one longitudinal record, which is why we are able to predict the risk in a much better way because we have the whole episodes there. We support all types of data sets, all VBC models, and all care settings, which helps us again have a full, complete 3D view of the patient. So if you look at the use cases provided by the Gartner's report, and if we follow the path, each one of the stages, during the identification phase, we are actually using a lot of natural language processing to identify patients whose risk is rising or is going to rise. We use both predictive and prescriptive AI modeling. So for with predictive, we are trying to forecast whether, let's say, the cost of a patient would rise in the near future. For prescriptive, our models tell us how to manage or what to do specifically in each of these cases. So once we have identified a cohort, it might be millions of patients. So which ones to prioritize? We don't have infinite resources to handle, let's say, 100,000 patients. So in the stratification phase, again, we use different predictive and prescriptive models to focus on the highest risk or highest value patients, and then go ahead and engage with them. So you'll be hearing a lot of generative AI models, a lot of noise in the market regarding generative AI models. They come on into their own during this engagement and management phase. So we're using these generative AI models to auto compose these clinical messages and to generate these patient education summaries that we hand over during the discharge phases. Uh, but these phases also include both prescriptive AI models that are helping the generative AI models with all this document generation. And in the end, we're using both predictive and prescriptive modeling to look at the outcomes, to analyze the data, whether a particular care program is successful, how to improve it, and go back to the drawing board to add more data points to have a better cohort, and keep improving the whole process. So this is where a high level view, where in each one of the use cases identified by Gartner, Persivia is already actively engaging and putting it into our product. So with that, I'll hand over to Hassan, who will actually go take you through the whole workflow.
As Dr. Hamad said, by the way, thank you so much for this insightful, detailed way of telling that what Persivia actually is doing. Now that we've already mentioned that Hassan will be talking about the real world examples of successful AI implementations in care management and how you can discover the winning strategies that will help you navigate this new territory. So, Hassan, the stage is all yours.
Thank you, Nida, and thank you, Dr. Hamad. So I will be discussing the utilization of the different AI models, especially how these help the care managers, because that's the end goal. As the world is progressing into more and more AI technology, I think the main focus is how to help the users in every application. So same would be the focus here. So with all the extensive research and everything, but the problem statement is how it's going to help the end user, especially the care managers if we are focusing on the care management platform. So one of the main challenge before we dive into these AI supported modules in Persivia platforms. So one of the most important challenge is how to make AI technology integrate with the day-to-day workflows. Especially the trend is to go towards the hybrid technology in which the AI models should aid the end users to make the right decisions and increase their productivity. So all of the Persevia models will be focusing on this one particular goal, like how AI models can aid the care managers in improving their productivity, in their performance, and of course the patient outcomes as well. So here we have a list of different modules, starting from the customizable programs to the risk stratification and the workflows and the patient engagement to the HCC opportunities and NLP for the unstructured data to the reporting. So this is the full life cycle, starting from the customizable programs and ending to the ad hoc reporting. So we will be discussing each one of these one by one in detail, and we'll discuss how it helps the care managers. So next slide, Nida. So first of all, the customizable programs. The word customizable is the most important one here because some of the programs are published by the CMS for the different care management protocols. Most common ones are the CCM and the TCMs, and there are a couple more as well. If any ACO organizations or if the team of the care managers wants to participate in those programs, our application of course helps. But the most competitive advantage in these modules is the customization of it. So what that means is based on the business needs of each group, we can customize our logic or completely create a new program on the new logic at all, right? So by using our AI modules, we can help the business leaders to create their own programs for themselves. So it starts with the very first step is define the criteria. There could be a range of different criterias if any business leader wants their team to work on. And the next step would be utilize the AI model to learn that logic and then evaluate the patient records on that logic and to give the results to the end users at the end. So this is a very high level and very simplified version. 3 steps: define the logic, integrate with the AI models, and then the most important step is to present that information to the care managers, care providers, and everyone. Next slide. So as I said, let's try to see it from an example. So for example, we have a business team or the care management team who wants to help the patients who are at home, like homebound due to some of their clinical conditions. They cannot come to the hospitals. This is the problem statement. Like we want to reach out to the patients who are homebound. Right. So this is a good example for the customizable program. How Persivia can help here, we can sit with the leaders and we can try to come up with the different logics to identify the patients who are at home. For example, the patients are in pre or post transplant condition. A patient could be a heart patient in which they have the symptoms of the palpitations or the fatigue once they try to move. Or another simple example could be patient don't have any conveyance to reach out to the hospitals, or it could be any other factors. As you have noticed, these are not all the clinical factors. Some of them are, but some of them the non-clinical factors as well. Now the challenge is how to identify the patients which are homebound. Right. If you could stay back on the previous slide, Nida. So first step was to define the logic. So we just discussed we can come up with the clinical and non-clinical factors, identify those factors, and just through a simple user interface, we can select those criterias and save it. And then our AI model will take that information which is saved for this particular program and start evaluating the patients which are homebound. We could call this program as care at home program, or we could have any other name. So you see through this, a very custom programs can be built quickly, like in less than an hour, and then can be deployed on production, and the patients will be start evaluating against these criterias, and then the care managers can use simple filtration mechanism to find those patient lists and start their workflows. Next one. The next step is, or the another modules that Persivia Care Management Platform has is the risk stratification. So Dr. Shardul and Dr. Hammad also discussed about this one as well. So at high level, we have multiple data streams. Some of the most important ones are the EMR stream, from where we are getting all the EMR data. There could be a financial stream where we have all the cost information, and there could be another one, for example, the utilization of the patients. through different HIEs, patients are visiting different hospitals, and we are gathering that information. Now, to create the longitudinal health records of out of all these data streams, either we can create some AI models to risk stratify the patients into different buckets. A common example could be highly complex, high risk, or the rising risk, so that the care management teams can appropriately reach out to those patients and starts taking care of them, or there could be a multiple or range of business objectives. A few of them could be avoid readmissions or improve the patient outcomes. So risk stratification is basically at the core is creating different buckets of the patients, utilizing those data streams, feeding that information to our AI model, and then creating different buckets in real time for the end users so that they can start their workflows. Next one, yeah. So I briefly touched upon in this one, identify the high risk patients. So first step is to integrate the patient different data streams into one longitudinal health record of the patient, and then defining the logic for this. Now different clients could have their own use case to define a patient as a high risk. Commercial payers could have some different logics, or some different ACU organization could have their own logic for it, or it could be a new one. It could be anything. So the trick is to be able to quickly adjust to these new requirements to define those criteria, just like we did for the programs. We can create the new logic for the high risk, utilizing those risk population. We can create the different buckets for the patients, or for the business leaders, so that they can reach out to the patients, and they can just use a range of different filters to reach out to those targeted patient list and start reaching out to them for different care management goals. So here is the list of the some common scores that Persivia care management platform has. One of them is a SSR. Soliton is an AI engine which suggests a risk score for the patient. Another could be the HCC risk score of the patients. And then we have a clinical risk score, patient prioritization scores, which helps to prioritize patients. So if we have a range of highly complex patients, we could have different prioritization matrix that helps us to identify the patients. And then we have the cost score. We have some ADI modeling based on the patient demographic factors. We can risk stratify the patients. And then we have the patient activation measures, LACE score, LACE plus, STUH score, or anything. Now the next step is user workflows. So before we start discussing these, as I said, in the customizable programs, in the risk stratification, our main focus was the identification of the patients to whom we want to reach out for the better outcomes, or anything. Now, after we identify the patient lists, the next step is to initiate some workflows. Usually what happens is there is a series of steps that each of your team member is supposed to be doing. An example could be they could be uh, calling the patient, scheduling the patient, and then creating care plans and then assessments, these kind of things. But that depends upon their workflow from organization to organization. So the use of AI in this particular module is how we can automate these kind of things so that we can reduce the cost on the user training, we can improve the user performance. So the idea behind this particular module is we can create a workflow. A workflow is just an automation of the user task in series, one after the other, that software can present to them so that they don't have to navigate into the different particular sections of the application and try to uh, find what do I have to do, especially for the new users, especially for the applications which are not in the public domain. These are very complex and require some domain knowledge to use it. To target this, we want to automate everything for the users so that we can only ask the user to do something if something requires some manual intervention, and that also in a form of some work list for the users, which they can use by simply clicking the task and just completing it, and you know just logging out for the day, so that they don't have to think too much about it. Let's see an example of it. So for example, we could have a workflow managing TCM patients. So as I said, the first step is to identify the steps. The very first one, for the managing TCM patients, the steps could be, first of all, as I said, identify the patients, because this is a TCM program. So we want to focus on the patients which are discharged to the home from the hospital. That's the first step. The second step is schedule those patients for the telephonic encounter. So we need to create a schedule and then talk to those patients. Do some documentation. The third step could be if the patients are not reachable or these kind of things. And the last step is to schedule a patient for the face-to-face visit. So that's just the basic definition for the TCM program. Now, if we have the steps, these are the four steps, how we can automate it. The very first step is can be done easily. For example, system should be able to, once we feed the logic to the model, model should be able to predict or should return the list of the patients which are discharged to home. Now, the second step is to schedule the patients, right? So the patients could be, they can reach out. So we need to create a schedule, a task for the care managers, so that they can, they know, okay, I have to schedule this patient. And the third step could be, if could be a branching logic. If somebody is not reachable, they can create uh, a reminder for them to call them again, and then schedule the patient again after 2 weeks for the face-to-face visit. So very first step, can we can do the automation there, and we can create a home screen where they can log in and go, okay, how many patients I have to schedule today, how many patients do I have to call back again. They can just click the name of the task. It should open some pop-up, ask for them to put in the right information, and they can just close it. So without going into any other module, they can just land on the home page, perform their day-to-day steps, and they can just complete all of their steps and then log out. So now what's the benefits? We can identify, first benefit is we don't need much training for it, because it's just a very simple interface. The second is we can monitor the performance. Each care managers can be tracked, how many calls they have made, how many patients they reached out, what's the performance, what are the best performers, what are the worst performers, these kind of things the leaders can see. And we can able to identify the bottlenecks in the workflow. For example, uh, the fourth step could be the bottleneck. Maybe our team members are not able to schedule the patients for the face-to-face visit, right? This could be the last. This could be a step which requires some improvement. So this is the very useful insight which the team leads can look into and try to either automate it or maybe try to resolve the problems which are causing this bottleneck. So workflow as a whole, reduce the training cost, improve performance, and able to identify the bottlenecks for a particular workflow. Now, the patient engagement. In all of the care management workflows, one or the other, we have to reach out to the patients, be it a CCM programs or the TCM program, or some care gap in which we have to close the gaps for the patients. So patient engagement is one of the most crucial point in which we have to create some SMS or some emails or any content that we have to send to the patient. And then obviously that should be specific to each of the patient's crucial clinical needs. So that's a time taking step. So how we can make use of AI to improve the performance again, and make life easy for the care managers, especially when it comes to patient management. So next slide, we have an example. So now, at this point, we have the patient longitudinal health records from financial, from utilizations, from all of these kind of things. Now, the goal is to identify the gaps in the patient care. For example, there could be a diabetic patient who is supposed to have their A1C test done in every 6 months. This could be an example of the care gap, or it could be another clinical care gap. So now we have the data, our AI model can continuously read the patient data and predict some gaps. Once we have the gaps, now we have to reach out to the patient or create some content for those patients. Now our AI model can take that information that we have generated in the very first step, which is list of all the patient care gaps. Our model can automatically generate a, a content which is catered or which is specific to the clinical needs of that patient. And obviously it can create this kind of content for like hundreds of patients at once. Now, as a care manager, I just need to go to my home screen. I would see a list of the patients that I'm supposed to reach out, or list of all the patients who have their care gaps not addressed. I can, if I want to review the SMS or the emails, I can easily browse it and see, okay, this is the SMS that I have to send. Or if I'm okay after doing 3 or 4 patients, I can just click send. In one simple click, I can reach out to the hundreds of patients for their own specific care gaps. I'm stressing again and again on the specific because nobody wants to receive a generic SMS, even for some, even for the birthdays. I personally, I wouldn't reach out if I feel this is a template message or it's just a spam, right? But if somebody address, okay, Hassan, you have this problem and your this test is due, please reach out. So if you feel the kind of connection you create with the patient so that they reach out back, so that's where AI model helps to create patient responses or generate more patient responses. At the same time, only 1 or 2 care managers can take care of more than hundreds of patients at once. HCC opportunities, another very important modules in which the main goal is highlights the areas needing documentation improvement, analyze the data to identify the HCC risk opportunities, and providers can review and accept the opportunities. Well, these are the just 3 lines, but the idea behind this one is uh, the HCC risk stratification mainly works based on the patient clinical or the patient's chronic or the acute conditions. Now, it's very important to correctly document these chronic conditions or the acute conditions correctly into the EHR systems, or when if we are reporting back to the peers or anyone who is responsible for creating these kind of scores. Uh, but if something is not documented properly, obviously the scores cannot be calculated properly. There could be maybe overestimation, or in this case could be underestimation of it. Maybe patient has a higher risk level, but obviously something is not being documented correctly. Now obviously the score is not correct, and then care manager obviously will not be able to reach out to the patient for their specific needs. So the goal is to document these conditions in the patient records correctly. So our AI models, since we have year-on-year data collection and all from all the different data streams, we can create the longitudinal health records, and our specified HCC specified models can predict if the patient is diabetes, and if something is not documented correctly in this year, the system can quickly create an alert like this is your opportunity. By opportunity means some if this is not present in this year in this patient profile, please accept it, this opportunity, so that it can be documented properly into the patient record. And only then, if something is documented properly, it could increase the HCC risk score, or not increase it. The end goal is to correct it. If it's underreported, we need to correct it. So our AI models can continuously read through the patient structured and unstructured data, especially the patient notes or from patient claims or from clinical inference. For example, we have patient medications, we can read it, we can, if something is not documented in the problem list, but we have an evidence in the patient lab results or in the patient medications, we can predict that this patient does have diabetes. So we can show this as an opportunity so that the scribes or the different CDI teams can take a look at it, those opportunities. And then obviously this is an hybrid way of helping the care managers. They have the final say if they want something to be accepted or rejected, or they can add some additional steps there. So overall, how we help in the HCC is we identify the medication or documentation gaps through use of medications, through lab results, through all the clinical factors, through patient notes, and try to predict if some patient has a diagnosis, and if system thinks is confident, if the system is confident enough, we show that information or present that information to the team so that they can accept that information and correct the documentation gap. Next one. NLP for the patient notes. Patient notes is a big thing, especially how this is being treated differently than the other clinical sections. That's the answer is these are the unstructured notes. From patient problem list, patient medications, we have a pretty standard libraries and everything is the structured data source. So system can use that information. But when it comes to patient notes, there are no defined structures. But at the same time, it has a range of useful information which can feed the other useful algorithms for the patients, starting from the programs for the from the HCCs for the risk stratification. In fact, in everything. So it kind of supplements the patient data by reading the useful information. So our AI model uh, reads the patient notes and some predict the patient missing diagnosis or, or or maybe some lab results, some crucial vital information, or patient inpatient stays. If during the inpatient stays, if the patient was on in ICU, the whole range of information we can collect from the notes and then suggest to the users this is also a useful information if you want this to be integrated into the patient record as well or not, so that it is useful for the even for the other algorithms. So some of the most common thing is diagnosis prediction. So that means is it's not prediction, it means something was missed in the structured data source, and now we have gathered some evidence from the notes that this patient has. Maybe this patient is taking some warfarin medicine, which is very important one for the cardiovascular patient. So this is a useful information the care managers can take help from. Or phenotypic classification. This is just a way if something is coded as simple diabetes, but we have the evidence this patient has a diabetes with complications, eye complications, or there could be different type of complications. And if we find the evidence from the patient notes, we can amplify or correctly classify the diabetes. So this is the phenotypic classification of diseases using the patient notes. And as I said, the diagnosis prediction, especially in which if we get the evidence that the patient is taking digoxin, which is a medicine for the heart patient, but this patient does not have evidence of the heart patient in the diagnosis list, maybe our system can predict that this is a heart patient. Otherwise, why would he be taking digoxin? So again, the final say is in the hands of the care manager so that they can verify that information or if they want to accept it or reject it. But our system helps them in their day-to-day workflows. Next one. Yeah, so and this one is just talking about again from the how we can correct the problem codes, how we can find the additional diagnosis, or there could be a disease interactions, there could be comorbidities, or maybe some maybe medications could be contraindicated into the patient as per the patient records. One common example could be if the patient has INR not normal INR, that this patient's warfarin dosage needs to be adjusted. This is a very crucial information for the patient outcome because the two things are interacting from each other. If any one of those are missing, uh, because maybe patient is going to different providers and those providers are not aware of the patient's health, what's going on with the other providers. So these kind of things, now Persivia is the main hub collecting data from all the different sources. If we get the evidence that this might be the case, we can generate an alert for the care manager so that they can address this problem or reach out to the patients. Or again, notes could feed into the risk stratification, patient engagement, and improve or correct the HCC codes as well. Last but not the least, ad hoc reporting, because whenever a teams are working or reaching out to the patient, the most important thing for the leaders is the reporting piece. Like, what's the big picture? What's going on? How many patients have we uh, managed? What were the outcomes of those management programs? These kind of things. So Persivia takes the reporting to the next stage without any knowledge or the technical knowledge of how to run queries. Because if you try to, before ad hoc reporting, if you try to create some specific reports for the users, so it's an infinite cycle. You get the requirements, you create a chart for the report, and then you go back uh, for each sprint. Maybe it's a 2 to 3 week cycle. So now you are, and then obviously there will be a new requirement. Maybe business leaders want to see some additional column there. Now you have to go back to the drawing board, create another report, go back again every 3 weeks or 4 weeks. So this is a never-ending cycle, reporting the requirements, especially in the software industry, and even in the reporting. When it comes to reporting, the requirements could change every minute. So the main solution is to give power to the end users themselves so that they can run the reports or they can tweak their reports. They can run some what if analysis. What if the cost is high, but the patient is not diabetes, but taking medication, these kind of things. Because when it comes to decision making, obviously stakes are high and everyone wants to run the different scenarios. So that's where the word ad hoc comes. But now, if we want to see the competitive ad hoc reportings, it's very complex to use. You need to, different jargons for the data science. What is the domain? What is the series? What is this? What is that? It's not very easy to use, even for the people working in the software industry. So the main goal is how we can make it easy to use, and that's where this AI-supported ad hoc reporting is, which takes input in the simple natural language. If you could go to the next, I think there's an example there. So the idea behind this is take the input in the natural language. User can just speak it or just write it. Give me the patients which are diabetic and high cost and going to provider John Doe, because that's the clinic we want to take some decisions, right? So I just need to type this information in the very simple box, and the system would convert this query into the SQL query or whatever the data model we are choosing. So it would convert this natural language into the technical query and run this onto the database and return the results that user is expecting to see. And then they can just export the data. The benefits are no need for the SQL or the Mongo or any kind of database knowledge is required for this one. It's very quick, and obviously you can just change your queries. You can just remove it and then run a new query, and obviously it's in real time. So it greatly not only reduces the cost of making the changes into the software itself, but also it gives the powers to the end users or the business leaders so that they can run the different simulations or the what if scenarios, and maybe they can come back again to create a new program, which was the very first step where we started how to create a new program. So doing this kind of analysis, they can make a decision, okay, we need a new program in which patients who are not taking medications properly, we need to reach out to them. So in this way, we kind of complete the loops, taking help from the different AI models in each step, making the life of the end users easy. And at the same time, obviously, we need to improve the patient outcomes. That's the very end goal for all the care teams using our software. Thank you, Nida. That's all I think from my side.
Thank you. So now it's time to transition into the QA session. And a quick reminder for you all, please drop your question in the Q&A panel if you haven't yet. So let's begin. So we have three questions. The first is that you've mentioned different data feed. Currently, Persivia has any connection with any payers in Michigan? Maybe Dr. Shardul, you can answer this. Different data feed. Currently, Persivia has any connection with any payers in Michigan?
Sure. So for some of our clients in Michigan, we do have mul many different payer fees that are in place. For one of our clients alone, we have about 8 to 10 different payer fees that we're taking into the system, and that includes um, different payer gap files as well as um, direct claims feeds as well. We also submit supplemental data on behalf of our clients to their commercial health plans and different payers as well in whatever file formats that those different payers require.
Okay, thank you so much. And another question is by Abdul Kabir that once a gap is identified, who is actually responsible for correcting it in the EHR? Hassan, maybe you can answer this one.
Yeah, so basically it depends on the workflow for each of the organization. Some of the organizations have some billers workflow who works on the EMR data, or some quality teams or the medical assistants who are supposed, once the gap is identified and they know that this patient has an upcoming appointment in next week, so they need to let the provider know that this patient has three care gaps open, so that the providers at the end, again, this it also depends from gap to gap. Some of the gaps needs to be closed by the provider itself. So yeah, so our application helps in providing the right information. It could be provider, it could be a biller, or it could be anything. So once we provide that information, that the next question is what's the workflow, so that our use case adjusts to that workflow. Hope it answers the question.
Great, thank you. Uh, Dr. Farhan has another question. Is Persivia using AI models with any of the clients? Maybe Dr. Hamad, you can answer this one.
Sure. These workflows are already integrated for all the clients. The ad hoc reporting is being used by multiple clients, particularly Prime, I think. And the other care gaps are identified across multiple clients. So yes, I mean almost all clients are using one of these modules. So it's already integrated into the workflow on all modules. So multiple clients are using it right now.
Great, thank you so much. So I have another question for you, Hassan. So how long does it take to configure a workflow, and do we need specialized training to do it?
Yeah, so that's the main thing. So it takes less than an hour. It's a very simple. You just draw the boxes and just link one box to another, which we call nodes, or the, in simple words, these are just the list of the tasks that your team is supposed to be doing. So technically it's less than 1 hour job to create a workflow and then just publish it. We don't have to redeploy anything. And sorry, what was the second piece, Nida?
And do we need any specialized
Special
training to
training.
do it?
Right. So the main idea behind the workflow creation is to move away from the training. So we don't want to create a need for more training, right? So you don't have to train it. You just need to meet with any of the business leader or the team leader or anyone. Just create a workflow, put it on the production, and then the team would see the change on the home screen. They don't have to know or train on anything.
Great. Okay. So my next questions are actually for Dr. Hamad. So how can we make sure that AI solutions offered by a vendor are accurate?
So first of all, we have to be aware of all the biases that are coming. So which populations are we looking at? Are these all Medicare populations? Are these all 65 plus? So there will be biases coming in from that population. So we have to ensure that that data has been properly looked at and validated and have all the biases have been adjusted for. Then of course there has to be a proper QA quality analysis team that looks at the output coming out of these AI models. So biases plus proper QA in terms of having blind tests, so blind populations where you actually don't know where they're coming from. So to ensure that these models are generalized and they are not, let's say, a region specific or an organization specific. So some blind tests in the QA and biases while making those AI models.
Great, thank you so much. My next question actually is related to AI hallucinations. So, how does Persivia actually deal with these AI hallucinations and talking about AI generating fictional information or making risky, far reaching assumptions?
So we have actually a lot of post-processing wrappers. So we don't directly give AI output to the users. So there's a lot of, as I said, QA checking scripts that ensure that the information that is going out is directly coming from our specific knowledge for that particular database and not from what the large language model learned from a generic um, set of sources. So there's a lot of post-processing checking that's going on and identifying and replacing any hallucination if there is any, using a lot of terms like prompt engineering, RAGs, um, and a bunch of other post-processing stuff. So it's absolutely the chances of hallucination in our models are less than 0.1% as of now.
Okay, thank you so much. One last question that how can health organizations overcome sunk costs when they plan to move towards advanced IT infrastructures to bring AI into care management and other functions?
Nida, can you repeat? This was
Sorry. How can healthcare organizations overcome sunk costs?
Shardul.
Sure, I can take this one. So that's a pretty tricky question. There's a few different ways that organizations can deal with that. So first, if your organization is already heavily invested in a monolithic or EHR-centric system, it's probably a good idea to take a step back and reassess. Sometimes it's possible to repurpose or reintegrate your existing systems into a new AI-driven platform without incurring any additional significant costs. Another option is, you can adopt a phase-based approach. Instead of trying to overhaul everything at once, gradually migrate towards a new AI-driven system. You can start by essentially you would start by sunsetting your legacy systems in phases and integrating new technologies little by little. This way, you can spread out the cost and the risk by making the transition a little bit smoother over time. Now, I guess another option is you can look at vendors who can address your most pressing pain points and help reduce overall costs. For this, it's critical to choose a partner who understands your specific challenges and can provide targeted solutions. So it'll help to improve overall efficiency and result in better return on your investment in the long run. All right, so I think that wraps up our webinar for today. Thank you all for joining.
Thanks, everyone.
Thank you, everybody.